Welcome everybody. Welcome to the webinar. I can see participants are slowly joining in, and once we get to 2:35, we will commence the webinar. Hopefully you all received your briefing, and we will commence shortly. So we still have more participants coming in. Whilst you're waiting, please do join the conversation at ILC UK hashtag Bridging the Gap. Please also, once the panelists start with their talks, please do use the Q&A feature at the top of the bar. You can put your questions throughout the session, and after each panel, I'll select questions to put to the panelists. We're going to start in 3 minutes. So more participants joining, this is great. Just another mention on the Twitter hashtag at ILC hashtag Bridging the Gap. Please do join us in the conversation on Bridging the Gap, bringing food, drugs and social connections to the home. We'll commence the webinar in 2 minutes. We have one question coming in asking if this session will be recorded. I am going to confirm with my colleague Matea whether it will be recorded. I think we shall record the webinar so that we will be able to release it later. We are going to commence the webinar in around 1 minute's time. Okay, we have final few participants coming in, which is fantastic. And just to confirm, yes, we will indeed have this webinar available to all the delegates following the webinar. We will send out a thank you email afterwards. Okay, so we're going to kick off now. Welcome everyone. My name is Redvers Lee. I'm the head of partnerships and development at the ILC. You can't see my face today. I've had to turn off my visual in order to save my audio. It was breaking up a little, but hopefully you can all hear me now, and that's absolutely fine. Many thanks for joining us on this webinar, Bridging the Gap, bringing food, drugs, and social connections to the home. This webinar is supported by EY, our long-standing partner, and who has been instrumental in bringing this webinar together with us. We're very grateful. So now for some quick housekeeping before we kickstart the session. Please put yourself on mute unless you're contributing. If you have any technical problems, please use the chat function, and our events colleague Matea will be with you to come back and help. Please use the Q&A feature, and you can use this throughout. Post your questions there, and I will, after each panel, take the questions and put them to the panelists. If you could help, it would be greatly appreciated by stating who you'd like the question to be put to and which organisation you're from. Please follow us also on Twitter and join the conversation at ILC UK hashtag Bridging the Gap. So this webinar was made possible through our partners program and especially EY. We work collaboratively with all of our partners. A big thank you to all of them. Together we ask important questions, we convene industry, bring business, charities, government together to help deal with the challenges that we face in an aging society. And we face a very big challenge right now, and that's why we are putting this webinar together. So what is our role in this? Why are we doing this webinar? Well, the ILC is the UK specialist think tank on the impact of longevity on society. We want to help government plan for what happens next, and this has never been more important. We're witnessing a crisis characterised by health, economic and social shocks that we've never seen before. And so ILC's role is to look at what's going on now, how society can adapt, and how we can plan for the future. So this is what we're doing today. We're shining a light on what's in front of us. I'm going to do the introductions now and just explain what we're going to explore, and then I'm going to run through the speakers. So this webinar is going to explore how business and charities across the country are responding to the coronavirus crisis, to help the most vulnerable in society to continue to access the goods and services that they need. We're going to discuss bringing health professionals to patients, getting essential products and services, including food and medication, into people's homes. And we're going to be talking about connecting the socially isolated. We've got an expert panel of speakers who will highlight how different industries are supporting vulnerable people, their experiences on the ground, the challenges they face and how they're dealing with these challenges. So we're joined by Rachel Dunscombe, CEO of NHS Digital Academy, CTO at Visionable, Class Arch Collaborative International Research Lead and Strategic Advisor to the NCA and Salford NHS Group. We've got Alan Lowe, who's the Chief Executive of health collaboration platform Visionable and NHS Manager by background. Alan started his career managing frontline services. Kevin Doran, founder of MoveFresh, an e-commerce vehicle for established FMCG direct-to-consumer brands in the UK. He's been involved in the technology sector since 1995, both as an executive and an investor. We have Paul Mayberry, the CEO of Pilltime, a multi-award-winning community pharmacist and the owner and managing director of a chain of pharmacies in South Wales. And we have Simon Hewitt-Averson with us, Director of Services at Independent Age. Simon has spent the last 10 years in the charity sector, working at Teenage Cancer Trust and Shine. Independent Age are a valued partner of ILC, and it's great to have them here. So the webinar is split into two parts, bringing food and drugs to home with Kevin and Paul, and connecting people to the crucial services with Rachel and Alan. And then Simon will provide a response and give Independent Age's perspective. There'll be opportunity for questions after each panel, and we want to hear your views, so please do submit your questions. Our speakers are waiting for your questions. I'm waiting for them, so please do use them. Don't be afraid of putting in too many. We can always follow up after. And please do use the feature at the bottom of the bar throughout. So I'm going to open up with panel one now, and I'm going to hand over to Kevin Doran.
Thanks very much. So I'm really glad to be here today, and I just wanted to talk a little bit about one of the businesses that we're involved in, which is called Parsley Box. And just to give you a bit of background, Parsley Box is a 3-year-old food delivery service, specifically started by Gordon and Adrian, the founders of this business, specifically because of their own mother's, or Gordon's own mother's, need. She was in her mid-70s. She'd had a life-changing event. She'd lost her husband, and she was basically looking for a food service, and Gordon and Adrian couldn't find anybody that apart from a couple of reasonable players that are in the market at the moment. And the business has been going for a couple of years, and really was growing very nicely. And then, as you can see from the little graph on the slide, was hit by the impact of COVID-19. To be honest, in a very positive way. But I think what I wanted really to talk about today was how we take food security for granted around in the Western world. We expect to be able to walk to a local retailer or supermarket and buy food and have our shelves full and be able to pick food up very easily. And, you know, UK grocery retail is 50% of all retail in the UK, and it has changed massively over the last 5 years. We were used to buying in stores, large supermarket stores, and they would have, you know, 40, 50,000 different products in those stores. So a wide range of choice, very accessible, and catered for lots of different niches. And online grocery has grown over the last 10 years and is about, you know, 7 to 10% of the grocery market. But within the demographic that we're talking about here, in the, you know, older population, online adoption is still very low. They all have access to the internet, they have smartphones, but they feel that they want a bit of a human connection. So this is exactly the service that Parsley Box provides. You know, bizarrely enough, we take checks, postal orders, telephone calls, and you can see from that graph that in the weeks of COVID starting, we saw a significant increase from, you know, customers and new and concerned children of those customers saying, well, how am I going to look after my parents, and how am I going to look after myself? And we're used to shopping on a weekly basis. So we're, you know, the weekly shop is something that we understand very well. And if you're then in lockdown for 12 weeks, that, you know, that changes your thought process quite massively, really. And storage within the home is relatively limited. Most of the other providers in the market use a frozen or a chilled supply chain, which means that you can only supply a certain amount of meals to vulnerable customers throughout the UK. And we've seen a massive increase in demand, and, you know, the essential service that we provide is an excellent example of, you know, the use of technology, the use of the ability to speak to customers when, you know, traditional retailers couldn't cope. We have seen, luckily, you know, quite a few retailers now offering additional services. Morrison's are now offering a service where you can phone and try and get a delivery slot, or you can phone and get an essential box of items. But there is definitely a requirement for more specialist services, and I just wanted to highlight one of the few reasons that is. The shift away from more traditional grocery retailers, the big box retailers, as I would call them, the Tesco's, the Sainsbury's and Waitrose of this world, to smaller retailers or smaller discounters, as they're called in the industry, such as Aldi and Lidl, has meant that choice is dramatically limited. So I talked earlier about 30 to 40,000 products in a traditional retailer, a big box retailer, down to probably 3,000 or 4,000 products. So that means that the average consumer, not only in our demographic that we're talking about today, but generally has got less choice. And that has seen an explosion in online purchases over the last 4 or 5 years, but I think specifically over the last 2 or 3 weeks. But certainly this demographic does feel quite uncomfortable at the moment in making certainly first purchases online. They feel that they really need to speak to somebody. And again, most traditional retailers don't have that service available. So I see there's a massive amount of opportunity to try and service this demographic. But I think there's also another part to that, which is trying to look at new services to order and provide these services rather than using traditional smartphones or laptops. So I see a big view of things like voice purchase. I think there's a great opportunity to be able to add stuff to my weekly shopping and have that delivered to the door. And I think some of those services we will start seeing are developing over the coming months. So Parsleybox was lucky that we actually were able to cope quite well with this increase in volume. We had to close our website down for 2 or 3 days to new customers to try and allow us to deal with social distancing within the warehouse and the ramifications of dealing with that. But we're now fully operational. We're offering a next day service throughout the UK. And yes, we've seen some benefit from highlighting the fact that food security is not something that we should take for granted. But I think we've also seen a highlight that there is niche areas within this sector that we need to think about, because really currently more traditional retailers in the UK don't specifically think about the elderly or vulnerable population and how they are going to service them. So that's a little introduction about Parsleybox. And I'm obviously happy when we talk about questions and answers to take some further Q&A.
Thank you, Kevin. That was really, really insightful. I especially, thought it was quite powerful what you said about no one, really thought that food security before this crisis was going to be an issue. That was really, that seemed like a powerful point there. And also providing the human connection, speaking is important, and the demographic that you're dealing with are finding that. So that's fascinating. I'm now going to pass over to Paul Mayberry, CEO of Hilltime, who is going to run through his slides. And then once Paul has finished, we're going to do the Q&As.
Thank you very much. Thanks for inviting me, and hello everybody. I'm a community pharmacist based in a community for the last 30 years and spent a lot of my time working with the elderly and vulnerable, and have won various awards looking in the public health sector and also in customer service. But in recent years, I was being drawn to these pouch dispensing. But as you can see from the slide, all the medication that you take at a particular time is pre-sorted in a easy to open, clearly labeled packet or pouch, which comes out of the box on a roll in the order that you need to take your medication. This is particularly important to help people that are confused by the medication. Now, depending on which studies you listen to, there are between 6 and 10 million people in England alone that take more than 5 medication items a day. We know that 50% of the general population don't take their medication as prescribed, are non-adherent, and that number increases with age and the number of medications you need to take. So I was particularly drawn to pouch dispensing. People are able to send their prescriptions to us by utilising the electronic prescription service, which is only available in England, and therefore our service is only available in England, even though my community pharmacies are based in Wales, Scotland and Northern Ireland still using paper prescriptions. In England, the electronic prescriptions means that anybody from anywhere in the country can sign up to us online. We become their nominated pharmacy. The next time they order a prescription, it's sent to us, and we go through the process of producing these pouches, along with any other non-pouch medications such as inhalers, liquids, creams, etc. The benefits then of getting the medication to you in home, we've seen that the most vulnerable, the over 70s, people with cardiac problems, respiratory problems, and diabetics, have been told to stay at home. It means it's difficult to get their medication in the same way that it is with food. But we've got this system, which means that you can sign up online or phone us through our customer service line, become one of our patients. You then order your prescription in the usual way with a doctor, it comes to us. It means that we then pouch your medication, we deliver it to your home using Royal Mail. All the medication is pre-sorted, as I've said, so that it's easy to remember, and you're getting the right medication at the right time every time. And again, particularly important because many of these people may be maybe reliant in normal times on carers, whether they're paid carers from agencies or family members that help them with their medication. If they're then left to their own devices, particularly if they've got a lot of polypharmacy, taking lots of medication, it can be very confusing of what to take at the right time. And if you do make medication errors, then you could end up in hospital. As you can see, there's a significant number of hospital admissions are due to medication-related errors. So without your regular carer available, the system helps you to take the right medication at the right time, every time. And as our slogan goes, medication made simple. But the online pharmacy world is less than 2%. Less than 2% of all prescriptions in the UK are from online pharmacies, and it's growing significantly. And obviously, the COVID issue has speeded that along at a tremendous pace. We use robots to dispense the pouches, and we also then use artificial intelligence and optical technology to check every pouch. So although this pouch doesn't show the barcode, usually our pouches have got well, the newer pouches now, they've all got barcodes, which means that they go through an optical checker. The checker reads the barcode, so knows what's in the pouch. It compares it to the image of what's inside the pouch to make sure everything is correct. So it's a very accurate way of dispensing. So reduces medication errors. It reduces administration errors because everything is there clearly labeled in the easy to open pouches, and improves adherence. So I would usually say that one of the messages that we try to get across is that making sure you take your medication as prescribed is a lot cheaper for the NHS, because by helping people take their medication as prescribed by their doctor, it means they're more likely to control their condition, and therefore less likely to suffer from long-term complications later on in life, which is good for the patient, but also cheaper for the NHS because they're not paying for the expensive hospital admissions and the long-term cost of caring for those patients. But it's even more important these days with the COVID issue, because although we know that we've got the at-risk people, and certain people at certain morbidities have got a higher risk of suffering from serious complications when they catch the virus, that risk is much higher if the patient's condition isn't controlled. So by helping them to take the right medication at the right time and controlling their condition, it lessens the risk of suffering from serious complications of COVID. By having your medication in these pouches, not only does it mean that as you get older, you can maintain your independence longer, look after your own medication before needing a carer, but it also allows people to be discharged from hospitals quicker and free up beds quicker, particularly important during this time. We're working with hospitals and software companies to allow integration directly with the hospital dispensing systems, so the hospitals can issue a prescription directly to us. We can create the pouches and deliver them to the patient's home in time for them to get to their house before they've left the hospital, speeding up the hospital discharge procedure. So you can see there's a number of different things that the pouches do, and having the medication dispensed in this way that helps people, as the slogan goes, it helps people stay at home, protect the NHS by keeping the pressure off the NHS, and hopefully saving lives. Thank you very much.
Paul, thank you very much. That was really, really interesting, harnessing technology to get important drugs to people that need them in a systematic and very creative way. I am now going to go to questions. We've got quite a few of them. Apologies if we can't get all of them. I'm going to start with one question from Andrea Lamble, and I'm going to put this to you, Paul. So Andrea Lamble is medical anthropology PhD student at Durham University. The crisis has highlighted the role of the wider health workforce as described in Making Every Contact Count, public health initiative. How does this panel envisage the concept of MECC post-COVID in the linking of health professionals to isolated people?
making every contact count.
If you're not aware of this initiative, we can move on to the next question.
Yeah, I am aware of the initiative. I'm just wondering how it relates to what we're doing with the pouch dispensing, because even though we help people take the medication, and I suppose it's the opposite to every contact count, because it means it means that people are not having to rely on other people and getting so many contact points with other people, because they're being more independent and looking after their own medication. Does that make sense?
Yes, and Andrea, you could always unmute and follow in with that question if you wanted. But I guess, Paul, you're saying that there's a slight conflict there, and is two different sort of processes offering different solutions.
Yeah, I think in a community pharmacy, we are aware of the every contact counts, and we're using those touch points as publicized recently, with trying to highlight obesity to the public, or even smoking cessation. And whenever somebody comes in for whatever sort of minor ailment they may be suffering from, community pharmacists are encouraged to make every contact count. But I think from an online pharmacy's point of view, we're more about making life simpler for the patient, improving customer service, making sure that we're taking away barriers to getting the medication, and therefore not contacting patients about other things, as opposed to what happens in a community pharmacy.
That's great, thank you, Paul. We have many questions rolling in, so I'm going to leave that question there. Thank you, Andrea, for providing that. Thank you, Paul, for your response. We have a question from our managing director, actually, David Sinclair. It's good to see companies like Morrison's offering new services in response to COVID-19. And this one's for Kevin. So Kevin, why didn't they do it before? Why have big supermarkets seemingly ignored the potential for this huge market for older consumers?
It's David, it's a very interesting question. I mean, I do think that generally, we talk about silent generation. I think it's an overlooked part of the population. And generally retailers try to spend a lot of their time looking for growth, because they're all looking for areas where they can get revenue growth. And so you will notice that in quite a lot of retailers, there's been a big push in vegan meals, and although that is only still 1% of the population, there's been a big push by retailers in to try to get into premium services. And I think I'm hoping that we'll see a change from traditional retailers in the UK, where they will actually see this as something that isn't just a requirement while lockdown is on, or while this current situation is, but they will actually broaden their services to think about this demographic specifically. They've generally been driving costs down by removing contact centres, removing the ability to pay by cash, try and make it more for the general populace. And I'm hoping that that's going to change. I don't think it's purely around profit. I think it's just that they had never specifically thought about this problem.
Thank you, Kevin. I think we've got time for one more before we move on to the next panel, and this one is directed to Paul. So it's in relation to someone's grandma. Rebecca Taylor's grandma had macular degeneration in later life, and her vision was limited. So can pouches be adapted for people who are blind or partially sighted?
Well, I think that they are already. I think it's a much easier way to take your medication if you're than taking original packs. If you are partially sighted. My father has got exactly the same as a type 2 diabetic, suffering from macular degeneration now. He loves the pouches because he knows that the print is bigger on the pouching. It can say exactly when and which pouch you need to take and when, and then he's assured by experience that every medication within the pouch is accurate. So rather than going through like the Dorset box in the question, which can be quite fiddly. And quite easy to drop things, or going through the original packs and popping them out of your packs and making sure you've got the right box, especially when lots of drugs can have very similar sounding names, or you could have the same drug with different strengths at different times of the day. With Pill Time, we pre-sort all that. You haven't got to worry about it. You just follow the instructions on the pack, which would just say Monday morning. Makes it easy for people with sight problems.
Thank you, Paul. I think we do have time for one more, but it's a very quick one or two sort of lines from the both of you on this, if you will, and we can start with Kevin and then go over to Paul. What are the cost implications for using Parsley Box or Pill Time? Does it cost more to use Parsley Box than other shopping? Tesco, Lidl, for instance?
No, it doesn't. I mean, it's a specialist service. So, I mean, our product's about enjoyment, so it's not purely about providing the essentials. So, you know, we do provide a lot of products out with the core meal service. But I mean, yes, you have to pay for delivery if you order under £20 worth of product, but it's the same price as you would pay with any other retailer. It's just that we are specialist in this area.
Thanks, Kevin.
And then with Pill Time, it's a free service. So we deliver to your door without charging you for the drugs or for the cost of postage. We're paid in the same way that any other community pharmacy is paid, by dispensing fees. But unlike a normal community pharmacy that we're paying for the expensive high street rent and rates, we're in an industrial unit where we use robots to dispense and robots to check. So we've got economies of scale. So our only additional cost compared to a community pharmacy is the postage, but we cover that cost because we're more efficient in the way that we dispense. So totally free to the user.
Excellent, thank you for that, Paul. That was great. Apologies to everyone who didn't manage to get their question answered. If you would like to follow up with your questions after the webinar, please feel free to forward them to myself, and I can be in touch with Paul and Kevin. So we're now going to move on to the second panel in this webinar. This part of the panel is called Connecting People to the Crucial Services, and I'm going to hand over to Rachel Dunscombe, CEO of NHS Digital Academy.
Thanks very much. And I really wanted to talk a little bit about Greater Manchester, actually. And funnily enough, I've actually got the unit dose pouches there because that was something that we were looking at. So around about a month ago, I got a call from Salford NCA Group, where I used to be Director of Digital. That covers around about half of Greater Manchester and provides the acute, community and social care services for the majority of that footprint. It was one of the first ICSs in the UK, so integrated care systems, and very much making every contact count is part of the ethos that we had there. What I was asked to do was to revisit what we'd done as part of the integrated care system and our digital exemplar, which was a set of monies that we got from NHS England to become one of the most digitally mature organisations and serve our populations. And the things that we looked at were how we would keep people safe at home in the community, and how we would do that with the sort of ethos that we'd used to create an ICS, an integrated care system, and accelerate that. So the first theme that I looked at was the medications themselves. So, you know, Paul's obviously talked about those unit dose pouches, and it's very important that we have that for some people, but even basic delivery of medications is very important. So me as a diabetic, actually, I've just had my prescription stopped by my doctors because I'm due a medication review and I used to get it posted. So they've stopped it and I've now got to go to the pharmacy to get it, even though I can't have a medication review. We've got some real issues in process. I even know that from my own family, in actually getting medications delivered and reliably prescribed. And if we're trying to get older people to get their medications and they need a medication review, say, and we're sending them to the pharmacy, we have both an issue of people signing up for these services reliably, but also for people falling out of those services because of process. So they're two of the issues that we've got. The second one is, it does overlap here on what Paul said, because we at Salford had embraced the idea of risk stratifying certain parts of our populations and trying to take forward unit dose in bags with them. Now, what you didn't actually see on the presentation, I think, from Paul, but, we certainly worked with Paul on, was actually barcodes. And I think there was a question there about accessibility. And what we as a healthcare system were looking at was a process. So making every contact count we talked about, but potentially in high risk situations with, individuals where you may have a carer going in and you want to know the medication has been taken, you may be able to scan a barcode, and you may be able to allow contacts to count by carers going in and joining together a set of services, which may be caring for the individual, making sure their medications are taken and recorded, and potentially things like telehealth appointments using technology to talk to nurses or doctors or whatever else. So in some cases, we have to ensure that we have carer supervision of the use of the technology. And there was a very good question that I saw come through earlier about the ability to make sure that we aren't allowing people to become digitally excluded. And that's something that really does need some consideration, and that varies between populations. So for us, all of these things need to be considered with that risk stratification for groups, both in terms of condition, in terms of age, and indeed, as we did in Greater Manchester, in terms of background, whether they're located with their family or individually, and what their social construct is as well. The next one was around the ability to actually access appointments, planned and unplanned, via, simple web browser access. And the reason I say that is when we did do the sort of population demographics and the sort of personas for the part of Manchester that we were working in, we had a lot of people that were on the margins of digital exclusion and some that were digitally excluded. Those on the margins of digital exclusion would have lower end devices and maybe a Kindle. So they still had something. And so what was really important, and I think is important for all of us, especially with certain groups that we work with, is to make sure that we have a lowest common denominator technology. So if we are doing telehealth appointments, this needs to work in a web browser with a simple Android phone or with a Kindle or whatever else. What we're seeing is a lot of these proliferations of technologies that need X, Y, or Z device and will only connect to X, Y, or Z device at the other end. And those things aren't going to work. What we need is a sort of open interoperability between devices, and that lowest common denominator is really web browsers. So that's really important to me, and that's one thing that we definitely found from Salford. The next thing is to actually look at those that are able to use devices but don't have them. And for us at the NCA group, they fell into two categories. Those people that had, say, Wi-Fi but needed a device that was capable of allowing them to receive emails or text messages, to get appointments and actually join them. And then those that didn't even have Wi-Fi. So we needed to provide them with either phones or tablets with a SIM card in them. And then the consideration which NCA Group are taking forward at the moment is how you curate a sort of group of apps that allow you to give an experience to those people that keep them safe at home. So telehealth tools. So, talking about what Paul said before, how do you get a medications review via video? How do you see a nurse? How do you see a doctor? How do you contact, for planned or unplanned care? How do you shop? How do you get your provisions? How do you talk to Kevin's team about, getting things via the internet? Or how do you contact your social circle as well? So, your kids, your grandkids, how do you participate in your neighborhood sort of Facebook group or whatever? So it's creating or curating an experience where people can participate in what is essential for their health, well-being and social contact. And that's something that's sort of evolving, but that bundle of apps, potentially as well with some of the apps from Orca, who curate apps for certain conditions, could make an experience that is comfortable and usable by the populations that need it. And that falls into the last point. So the last point was, when we did work with Salford and the NCA Group, we had some really challenging boroughs that we had to work with. So in some boroughs, our average reading age was 8. In some boroughs, we had 40% whose first language was not English, and so on. And so we had various different exclusions, some based on conditions, some based on age, some based on, different demographics. But what we did was we worked with Barclays, Age UK, and a few other people to create sort of programs to reach out to our populations and work with them on, digital skills. So what we did was we took the Barclays Digital Eagles program. We white labeled that so that we could help people to feel safe, secure, and confident and master the tools at home so that they could actually self-care, self-manage, and be as self-sufficient as they felt was appropriate. And that in turn allowed us to sort of serve them within the home, because the ethos of ICS's, integrated care systems, is to provide that care in or near the home. And so those learnings from our integrated care system approach are really something that have been, the accelerator pedal has been pressed down on in Manchester. And obviously I've now stepped away and I'm working, with Visionable and the Academy. But these things are, great learnings that we have been able to take forward from integrated care. And the making every contact count point is really important, because all of these things then need to be linked in to all of the different touch points you could have as an individual. And for instance, on those devices, you need the ability to link in a workflow to talk to a pharmacist, link in a workflow to talk to, the hospital. And to address that point around Paul, I absolutely agree, he's the end point. And I think, healthcare systems' job is to make a contact count, where actually you could break out into a medications review or break out into an appointment with a pharmacist or doctor. So for me, that's been the learnings that we've applied through parts of Manchester for safe isolation and communication. And hopefully that gives you an idea of some of the technologies that have been used.
Thank you very much, Rachel. I'm sure there will be lots of questions for you once we have finished this panel with Alan and Simon. Can I please remind everybody to keep the questions flowing? We may have time for an additional set of questions at the end. We're doing okay for time. Can I also please ask everybody listening to join the conversation at ILC UK, #Bridging the Gap. Thank you. I'm now going to hand over to the next speaker, Alan Lowe, Chief Executive of Visionable.
Hello, everyone. Thank you for inviting us to participate in this webinar. So as I said, my background is frontline staff in the NHS. I used to manage outpatients and cancer services. And then my final role was doing service improvement for patients. So I'm not technical by background. My passion was improving services for patients. So set up cancer user group, HIV user groups, and then just took those voices to deliver change to services in the NHS. So in 2008, I started to work with video and put together the first cancer network on the internet for the NHS, and started to just see the power of what video could do 12 years ago. And for the last 12 years, I've been doing a lot of national services, clinical services all around video. So it's become my day-to-day job for a very long time. And what I wanted to talk to you about today is the sort of role of video, how important that is, but really where it sits. And for me, it's a link in the chain of a clinical pathway or a workflow. So we very much think that the technology should adapt around the user, not that the user should have to adapt around the technology. And I'll give you some examples. So having done this for 12 years, you can imagine internet's got faster, devices have got faster, smaller, more consumer focused. So just starting with like sort of the NHS and healthcare as a whole, is that what's happening now has been happening. It's just now being accelerated. But with that acceleration, there's a challenge to do it in a coordinated way so that it does work in a clinical flow. So for example, patients at home, we did the first patients at home service 12 years ago for patients that were dying and didn't have enough hospice beds. So we had hospices at home where we would send patients a laptop and send them a Wi-Fi dongle that they'd put on their window. So I mean, it's come a long way since then, but the benefit there to the patient was just simply reassurance, convenience, reducing loneliness and so on. So since COVID, it's exploded, and everyone at NHS is trying to put different video solutions in place and different video services in place. The main ones that you're all seeing is a GP appointment. Let's keep the patients at home, isolated, but still keep them connected to the world. Now, that's happening all over now. So GP appointments are happening digitally, not just video, but also chat and audio. Outpatients is something we do a lot of all over the country. Now, outpatients could be anything from diabetes to one of the big ones is pediatrics and children, HIV, anything a sort of follow-up appointment. But with outpatients, there's a complexity, there's a different type of need sometimes. So sometimes it's not just video, you might need to share some type of medical data and so on. So what's happening in different scenarios, sometimes there's a bit pieces of hardware that does the monitoring that's linked to the video, and it all links through as a clinical pathway. Mental health is one of the big ones via video because you don't need any diagnostic equipment. So there's huge demand on mental health. And obviously with people being isolated and stuck at home, that we're seeing a huge spike in that. The need to access pharmacy from home and getting opinions from pharmacy rather than impacting the GP. So you think of it as a sort of ecosystem. The patient's at the center, and video allows the patient to connect to anyone they need to in their care pathway. Now, the challenge for the system is they have to reorganize old, 40-year-old clinical models around this new technology, which they were doing in pockets really well. Rachel was one of the industry leaders in transforming telemedicine. But what we're seeing is, how do you do that at scale? And then how do you do that at scale within 2 weeks or 3 weeks? It's becoming very challenging. So we're seeing a lot of services at home, but that's just the start of where video comes in. That's just getting your appointments, getting your information. There's now the social impact of video, as you probably all are experienced Friday nights and so on. You might be having video meetings and video parties and so on. So it's becoming a new norm. And the big thing we're doing in the NHS is community groups. So we used to do this physically. We'd have a cancer user group where they physically used to come to the hospital. Now what we're doing is we're having, those meetings remotely. So just new ways of working, but it's accelerating. Biggest thing that we are focusing on at the moment is obviously the in-hospital side of things, because regardless of whether you do video, you still need a doctor. It's still the doctor's time. It's still the clinician. It's still that access to that physician. And that was the challenge before COVID, where there's a workforce shortage. There's a 40% gap in stroke doctors in this country. So we have a telemedicine service where we can bring the stroke doctor at home into the A&E department and service any stroke service in the country. So with COVID-19, Rachel touched on that earlier, we are starting to do devices into the hospitals so that the sick can communicate to their patients, but also so the doctors can get access to expertise they need 24/7. We've also got services now in ambulances, and we're pioneering some 5G elements around connected ambulance and smart ambulance. But at the moment, the paramedic and the first responders can just take their phone, hit a button, and bring the expertise they need into their ear to help service patients. So I could go on for a long time about all the different services, but the key thing to remember is there's a lot of different nuances to this. So if you think elderly patients might want to have their son or a carer on the meeting who's not physically in the same room, so that becomes a three-way call. You might need translator services for some of the population, so you need to bring a translator in. So there's all these little nuances that make up a successful service. The big thing for the technology is getting it right. And I talk about fail points in these services. So to eliminate as many fail points is how you get a reliable, good service. It's impossible to eliminate every fail point. For example, if you talk about making it simple on your phone, you still have the fail point of the battery might run out. You still have the fail point of Wi-Fi isn't as good as a wired connection. So you've got to have trade-offs in the technology, but it absolutely has to be simple for the user. It absolutely has to work first time. And one of the challenges with healthcare services and NHS is it has to be secure, right? You can't have patients' data, doctors' information, being hacked and having access to. So you're trying to balance risk with accessibility. all the time. But I think that's the final thing for me is I think the benefits to patients is obvious here. It's convenient. It reduces social isolation and loneliness. It reduces the need to leave home. But just imagine a world that's coming now where at the moment you look at a video call, but imagine a world where the new pathway from end to end could be digital. So the old model, you take 2 weeks, you go to your GP. You take another 2-4 weeks to get to your outpatients, then another 6 weeks to get to your diagnosis, then treatment. So you're 6 months on a pathway, which some of it could all be done on the same day with the right access to expertise. So there's a new world coming. It just needs a lot of thought.
Thank you, Alan. That was great. I certainly get your point about getting technology right. Thank you for earlier suggesting that I turn my video off so that you can hear me. And to your point to Wi-Fi, I think that certainly rings true. Also thought your points around risk and accessibility were really pertinent. So thank you. We will have time for questions once we have heard from Simon Hewitt-Averson. So please do keep the questions coming in. I'm now going to move over to Simon, Director of Services at Independent Age.
Hi there, good afternoon. Thanks for having me. Thanks to ILC for the invite. Don't often start with apologies, but yeah, apologies. I'm not Deborah Alsina, and apologies that I don't balance the gender on the panel quite as well as perhaps Deborah would have done. But what I thought I'd do is just run you through what Independent Age has had to do in the last few weeks, and perhaps some of the insight that we've seen and heard from the people that we've been speaking to. So as you would have all aware, this has all happened fairly quickly. We as a senior leadership team got together on around the 10th of March and said almost jokingly, should we set up an incident response group? Should we start preparing for what happens if? And then 2 weeks later, we had to move 170 staff out of a London-based office fairly quickly. So this is the sort of the timeline of the last couple of weeks along the top, and then some of the insight we've seen along the bottom. So our immediate response, we had to very quickly prioritize our people, which includes obviously all our teams, but also the people that we support out in the communities. It meant shifting some of our business process, things like simple as paying people. We had to try and move all that online and off-site. And then we also needed to consider what our external response was going to be in terms of how we further help the sector. So we very quickly established some sort of basic groups and comms, and that was also alongside firefighting a lot of PR interest and activity over the first few days, people asking for comment on this, that, and the other. So within less than a week, we'd established a pretty good ways of working, utilizing all the tech that was available to us. And I think we've probably achieved more in the last 2 to 3 weeks in terms of our tech able workforce than we probably have in the last 2 years. So this has really focused our agile working ability, shall we say. We then began checking in on the 3,000 or so older people that we work with across the UK. We did have to momentarily pause our volunteer onboarding because of the sheer influx of applications we had. And I think this was a general theme we got in the early part of this crisis, was just the overwhelming sense of people wanting to help, not necessarily always knowing how to help or what to help or who to help. So that was an individual response from the community, but also from the corporate world as well, and then some of the foundations we work with. So one of the very early things we did was set up a screening, a mobilization group to look through the sheer number of offers and opportunities that we were coming through, to make sure that we were, I suppose, focusing our time on the right in the right areas. And we also realized very quickly that actually the community response to this was overwhelming and unbelievable. And so one of the things we did very early on was just to set up or give part of our site to celebrate and share all the great local initiatives that were going on. There was far more being done in the communities we could ever achieve ourselves, and I think we tried to provide a platform to share that with others as well. And through doing that, actually, we learned quite a lot, and we quickly picked up with others some of the early scams that were going on, and some of the ways that which people were trying to stay safe in the community. So again, we were able to elicit that insight and provide some further guidance to people on that as well. Moving on a few more days, then we have various members of a charity, as you can imagine, that are probably busier than others during a period of lockdown like this. So we trained additional 40 staff from across the organisation, repurposed them for a period of time to also phone and check in on the people we support. So at this point in time, after about 3 or 4 days, we'd actually managed to speak to 900 of the people that we support already. And at that point, actually, the fair amount were doing okay, but some were obviously not doing that well at all. And I'll come on to that in a minute. We established an insight group because we were getting a lot of information back and we needed to work out what we were going to do with it. And actually at that point, we also set up some phone-in coffee mornings. So within the space of 2 weeks, we're now running nearly 3 coffee morning phone-ins every day. And they've proved hugely popular amongst the population that we're working with. We then sort of got a little bit of a breathing space, I suppose, started sort of settling down into slightly more sort of more pattern. But we then started seeing an increased number of complex cases. We were speaking to individuals that was taking a lot of time and energy from our staff to try and plug them into the right services locally. And this was at the time where local hubs were starting to be organised. We had an influx of the mutual aid groups, but nothing at that point in time was being coordinated as well as it is right now. So it was taking quite a bit of resource to find the right places for individuals. We started forming various partnerships. So we started a partnership with an organisation called Grief Chat, who provide online bereavement counselling services, something that was in our strategy anyway, but actually this has sped those things up. And we're also working with a number of corporate partners as well in various areas. At this point, we also we have had approval from our board in terms of what we can do to help smaller organisations, and hopefully in the next week or two, we'll be able to announce our plans around that. And we also added a few additional comms channels to our own internal workings to try and bring some light in some of the dark for staff in terms of some of the more informal ways of communicating as well. And then on to sort of the end of last week, actually there was a real dip in morale within the teams. I think it's fair to say, and it was noticed across the board. I think the initial probably adrenaline piece had worn off, and actually that crisis of the crisis had sort of taken over, and people were now sort of realizing that actually we're in this potentially for the long haul, and also the nature of the calls we were starting to see were getting more and more harrowing. So we have introduced various wellbeing initiatives, and we're also now starting to increase our volunteer base again so we can deal with some of the increase in demand. So that's a very whistle-stop tour of what we've been up to. I suppose the 3 areas I wanted to pick on next were really the sort of what we've seen in the external landscape. So we've been talking to charities large and small, and I think it's fair to say there isn't a one-size-fits-all here. Some very small organisations are actually weathering this fairly well. There are some medium and larger charities that are really struggling with cash flow, and we've all seen some of the stories across the press around the numbers of staff being furloughed, etc. But charities with diverse income streams have really been hit hard by this, and unfortunately, I don't think the response from the government is going to, in terms of a financial package, is going to do much to stem some of that. We've been working quite closely with some of the emergency response groups, so the likes of the Red Cross. We've been working very hard with our corporate partners, looking at how we can leverage some of their skills, experience and abilities in some of these areas. We have been in constant communication with various departments within government, trying to get insight, but also feeding what we're hearing back. And we've also been working on that community level as well, looking at the local hubs and the community response. In terms of what we're hearing, so we've made nearly 3,000 calls now. Shopping, medication and access to cash have been a #1 priority throughout the whole thing. I think that's continuing and that's escalating, and what that's leading to is an increased level of stress and anxiety, a real worry amongst the population that we're working with. I think we're now starting to also see much more issues around care and social care in the home. So on 2 sides, one from the older person themselves being anxious or worried about the carers coming in and not necessarily having the PPE, not necessarily following protocol, and just being worried about contracting the virus. And then the other side of that is actually that the care providers haven't got the staff to actually provide the same level of care as they were providing before. So we are seeing reduced packages of care. We are seeing packages of care that are being withdrawn completely. and we are seeing people being discharged from hospital without the appropriate package of care in place as well. One of our teams in Barking went to visit a gentleman in his late 80s who had been discharged from hospital blind and was lying on the floor of his flat because the package of care had not been put in place. So these are real people having real life experiences right now, and I think when we're sort of thinking about stats and numbers, and it's quite easy to get lost in the big, but every one of these people is an individual that we have been speaking to. And I think one of the biggest things now coming through is this one around connection and connectivity. A lot of the people we've spoken to, it's those that have got family and friends, this has had a big impact on them. But actually, this has shown up even more clearly the divide between those that can and those that can't in terms of online and just that broader communication. So in terms of what happens next, I think it's probably just fair to say or to highlight that those people that were falling between the gaps before still are, and probably are falling through bigger gaps. We knew the social care system and the NHS were under pressure before. This continues, and again, I think we're going to need to think very carefully about how we come out of this. And there are some positives in this. It seems like people are starting to reframe the social care narrative slightly, but I think that we're going to need to keep pushing on that. I think what we're seeing, personally, I've seen through this ourselves, is actually there is a lot of value in low tech. And I think we probably need to all think about how we use that. And again, we're thinking about how we reposition some of our phone support services and how we complement that with some low tech as well. And then I think there is some things that we need to think about in terms of the medium to long term impact on this, in terms of the mental health with people being isolated, particularly those that were perhaps previously isolated as well. We're hearing a lot more from our volunteers than we normally would do, concerns around the individuals that they either visit or see, becoming more confused, becoming more uncertain. And I think, in the period of 2 to 3 weeks, to see that level of increase in sort of cognitive decline or anxiety is quite a worry to what that might lead to further down the track. And then I think there's a broader, bigger question around what civil society is going to look like. I think there will be some opportunities. I think there will be some positives, but I think there's also going to be a big shift in the way that charities like ours and others are going to have to work alongside public services moving forward.
Thank you, Simon. That was really, really good. I think it's great to get your experiences on the ground from the perspective of a major charity working in this space. Your expertise in older people, the challenges they face, isolated and vulnerable people in the UK. That was really useful. Thank you. I'm going to open up for questions now for Rachel, Alan, and yourself, Simon. I'm also going to potentially bring Kevin and Paul back in if we have a bit of extra time. We do have quite a few questions, but please feel free to continue to put them in. That would be great. And if you could also continue to use the Twitter hashtag to get the conversation going, that would also be fantastic. So I'm going to take a question from Aaron, actually from the ILC, and Rachel. This might be one for you. And actually, before we started, you gave a very interesting story about how a Zoom webinar you were on was hacked, and you had some interesting images coming through. So, to what extent does privacy concerns delay adopting of technology? Do we need to balance these risks against the most in need of those services? What might this look like?
So there are highly secure video technologies, as Alan will know. There are things that are suitable for clinical use, military use, high dependency, sort of scenario use. And from my days as a CIO, I absolutely know that we, sort of sought to security test and validate those. So I think the thing is with Zoom that it's not a technology that is meant for clinical use or for high risk industry use. It's something that's meant for people to have meetings together. And I certainly don't regard it as something that either from the usability or the security perspective would be something that I would use for clinical or sort of social care use. That it's not the right fit in any stretch of the imagination. I think it's interesting. People have been trying these different technologies, but, you know, as Alan's outlined, there are specifically some really, you know, great players that deal with the specific needs that we've got, like Visionable. We've got other people that do, you know, video in terms of, you know, operating theatres and so on, you know, very high resolution, so we can have remote surgeons. There are specialist players here, and I have absolutely seen, you know, assurances that they have taken security seriously. And again, we also use, you know, penetration testing and military testing to make sure that these security solutions are in place. We do that in the NHS. So it's about not taking what I'd call a corporate solution or a leisure or domestic solution and trying to apply it to, you know, clinical pathways and everything else. You have to choose according to your use case. I certainly wouldn't be using, you know, some of the social tools that I use for clinical scenarios. From every usability sense, from every security sense, they just don't meet the tick boxes.
Thank you, Rachel. I've actually got one from Masako here for Alan. Alan, and I think this is a question that many of you could probably answer. In that here at the ILC, you know, we're certainly interested to explore generally when we're talking about most subjects, but what can we do to make technology more accessible to older people? How do we ensure that people of all ages, not just older people, are comfortable using technology? Person-to-person on-site instructions might help. Question?
Yeah, it's an interesting one, because, you know, old people as a category is too broad. You know, you get people that are very technically users. I mean, so at the moment, like going back 10 years ago with our virtual hospice, we pre-programmed a laptop. So all the patient had to do was lift the lid and press a green button on the screen. That was all they had to do. Now you can do that with a link on a tablet or on a phone. But a lot of elderly people don't even have internet and don't even have phones. You know, so there's a real balance to it. I mean, personally, my opinion, I think the television is the future for the patient. I think they're used to remote controls, and you see smart televisions now which come with a Netflix button or an Amazon button on them. I think the future is television for the elderly. Now, short term, we've got some solutions where prior to COVID, where patients could go to the local community centre or a van comes round or so on. So there's mobile ways of, because I think it's 8 million people are digitally excluded in this country, is what I was told. So there's different solutions. But in terms of the design, I think coming back to Rachel's point as well, is it's the design for the condition. If it's just a GP appointment, it could simply be just a tablet or a phone. If it's something that needs a diagnostic, like if you're monitoring someone at home, it's post out, it's set up, and then it's leave to run type scenarios. But I think at the moment the simplest solution is one button, and that's all they have to press. I think that's the simplest you can get it at the moment.
Thank you, Alan. Yeah, I think there's another interesting question it's coming. You might be able to touch on, and I'd probably like to put this to Kevin as well afterwards, and Paul if he has any thoughts. And it's about the rural environment. You know, to your Wi-Fi point, Alan. You know, quite often in the rural environment the quality is poor, yet we need access to in-home medical services. So as patient travel is very difficult for the elderly, and you know, for people in vulnerable situations, vulnerable backgrounds. How do we prioritise those most in need here? And
so just on the connectivity side, from my side, you know, we're been invested in by O2, and we work closely with Verizon. So in the telco spectrum, I understand that space. Now, we've never come across a situation in the UK where we cannot connect via video. Now, one of the reasons we can do that is we can operate on very low bandwidth, and we set it accordingly. Just to give you a bit of technical, people talk about HD, you don't need HD to do a video conference meeting. We work on sort of smaller windows. So at the moment, I'm looking at, we're using Zoom, I'm on a small window, but I'm sending in HD. So I'm sending a megabit of data into a meeting, which only needs 100 kilobits. So a lot of the times there's too much bandwidth in the technology, to deal with the pipe size. The other thing in home a lot of times is contention on the pipe. If you've got people watching Netflix and streaming movies and playing PlayStation while you're trying to do a video consultation, that will also. So there's a bit about education, but the minimum broadband that's sold in the UK is more than enough to do a one-to-one video call. We've done a lot of things over satellite. So where it's rural, like Navy ships and oil rigs and medical applications there's no reason to not be able to connect a video call. So it's either going to be contention on your network or you're using a too high an end video conferencing, in my opinion.
Thank you, Alan. Kevin, I think it might also link to your point about using the telephone more, and people of certain ages do potentially feel more comfortable using the telephone. But what are your thoughts around that?
Well, I think the 2 points. I mean, so I think up until COVID hit, I think 70% of our contacts and our orders were taken by phone, and only 30% online. So that just tells you that that the adoption of technology is there, and there's a question there about on the Q&A about what is the adoption there. Everybody does have, or the majority of people do have technology. It's just how comfortable they are about using that. And one of the things that we brief to our team in our contact center is that there's no limit. Most contact center, it's all about call handling time. So there's no limit to call handling time. And in fact, my son was working over the summer last year in the contact center, and he actually had to help the person at the other end of the phone set their tablet up, rather than just because they were very determined about, they wanted to order online. So I do think that adoption is increasing, and I do think we will see it, but I think it's about simplicity, and I think we're still not there with simplicity. So I think you do, from my perspective, have to adapt to what is the requirement for the customer. How do they want to order? You need to adapt to that rather than just be prescriptive about you have to use online or you have to use telephone. And I think the other point you were mentioning was about rural. I mean, rural generally are badly served by services throughout the UK, in terms of whether that's pharmacy or online services like ours, or supermarkets. So we see that as quite an important part of our differentiation, is that we feel that we don't go to the areas specifically that are highly competitive and dense. We tend to try and focus on the areas that are badly served, because we've become a more vital service to those customers.
Thanks, Kevin. I'm going to bring in Rachel in a second, but I'd just like to see what Paul's thoughts are around this. How's Pill Time dealing with the difference between rural and urban communities?
I think it's easier for us because the tech that we use is all on the back end. So we've invested heavily in the robots that produce the pouches. We use optical recognition technology, artificial intelligence to make sure that the pouches are all accurate. But because of the clientele and the age profile of a clientele, we know that they like using the phone. So we've tried to make it as simple as possible and low tech to help people to order their prescriptions. They can order online, but they can also do it by text or by voice. We've got a call center where we spend a lot of time on the phone to our patients. And even in the setup of people's pouches, technology at the back end. So when somebody signs up, they can sign up online or over the phone, but then we access their summary care record with their say-so that we can see what medication they're taking. We work with their surgery in the background. We assess what needs to be taken at what time, what's going to go in the morning pouch, what's going to go in the night pouch, and design all that on the back end. But then from a patient's point of view, we want to make it as simple as possible. And then getting it out into rural areas, because we're using the Royal Mail they go everywhere anyway.
Brilliant, thank you. I've got one for Rachel here from Navpreet Singh. How can the rapid innovations that are implemented by the NHS due to COVID-19 be utilised to continue the momentum in addressing healthcare needs for at-risk groups and older adults and not be lost? So there's an example of the NHSE quickly identified and communicated to populations that needed shielding. How can we continue to use this platform to communicate about key health services post-COVID, so after the crisis?
That's a really good point, actually, because previously, I think what we had found was the commissioning system that we have in the UK did not incentivise innovation. And what I mean by that is we had false bounds between clinical commissioning groups, hospitals, social care, which didn't allow unified interventions. And certainly what you just talked about there, I mean, public health had been put into local authorities and wasn't necessarily looking at, risk stratifying populations in a sort of healthcare system way, because it had actually been pushed into, a different domain. So I think what we're going to see is a lot of reflection after COVID. And I think that will lead to reflection as well about the constructs in the system and also the incentives that were in the system, which stopped us doing the things we should have done before. One piece that I've been really, keen on in Manchester was that we'd done some risk stratification around video consultations, and we'd worked out that depending on the service, up to 80% of outpatients consultations could be done via video. And I remember sharing that with, NHSI and talking through what we'd done there. But actually, we couldn't do it because the tariffs and the commissioning in the system would have meant that as a hospital group and a community group, we would have lost out financially. And I think we're now going to look at this and say, why don't we do it? Well, this lever wasn't there, this commissioning wasn't there, there was this organisational bound. And I think we will see that change. The other thing I would love to see happen is blueprinting of what's worked and why it's worked, because actually we've been forced almost to do things, and certain things have been very, very successful. It's almost Darwinian. Some places have tried this, some places have tried that. And those things that have worked, we need to blueprint, take the evidence and, use that across the system. So I would say I have a call for an hour and a half every Sunday night with a group of CIOs across the country, so those leading digital in the healthcare systems, and we share our learnings and we talk about what's happening. But our conclusion is that there will be a big true up of lessons learned, and really we're hoping that we can use this to actually save and improve lives in the future, that out of a very bad crisis we really want to make some wonderful future things appear from the learnings that we've had, the difficult learnings that we've had, but also the things that have been unconstrained in delivery.
Thank you, Rachel. Keeping on the theme of post-COVID, and I'd like to bring in Kevin after you've answered this as well. Do you think older people and their families who started to use online services continue to do so when they're not isolated? So, for example, how will this change the way older people and their families shop in the future, or won't it?
I mean, I'm not sure that there will be a massive change. I mean, one of the things that I would have said is that it's trying to make tools easier for the demographic, the person themselves to shop and buy or use these services. I think it's up to the technology industry and us to try and do that, rather than expecting change from the consumer themselves. And so I'm really keen to make sure, I want to remain independent in my home, and so if you actually take that away from me by saying my kids or a friend have to shop for me, I'm instantly losing my independence. So I think, companies like us have to make it easier, and going back to Rachel's point about usability and simplicity, to actually use the services that will change adoption. But that's not going to be an overnight thing, and we shouldn't be pushing our customers to only choose one way to shop with us. I just don't think that's how any business should act.
Hmm. Thanks, Kevin. I've got another question actually here, and Kevin, you're free to answer this, and perhaps Alan might like to come in as well. Should government policymakers incentivize businesses to reach out to older customers, in particular during this crisis, or should it be left to businesses to make these decisions alone?
I mean, I suppose my view is that I think that there will be much more focus post-COVID on this demographic, which will give more choice. I'm not sure government intervention will help that, and I think what this has done is highlighted that there is a demographic that needs served differently from the rest of the UK population, and there is opportunities to get very great relationships with those customers that are long-term and are beneficial for the business and the consumer themselves if we focus on that. So I don't really want government intervention.
Right.
From my side, I think, economically, the elder generation is the one that puts the demand financially on the NHS. So there is an incentive to digitally enable the elderly from a financial perspective. We obviously at our core it's about care, but if you redesign commissioning models where patients aren't having to go to hospital multiple times a year, and reduce as much as you can, then obviously there is a financial incentive there. So I think it is in the interest to digitally enable the elderly. We talk about, there's from years gone by, we talk about almost putting devices in the homes, because the cost of one device versus the cost of one appointment, it pretty much pays for itself.
Redvers, can I just come in there? Sorry.
Yes, please do.
All right. It's been really interesting, I think, listening to the sort of connectivity point from, I suppose, our perspective. I think some of the polling and surveys we've done and just talking to older people is actually almost like 3 in 5 the people we spoke to didn't use technology because they didn't want to or didn't feel they needed to. So actually we probably need to start thinking about, in terms of behavior change, it's not about what we want. Actually, it's about making people realize it could be of benefit to them. And I think that's perhaps something that we haven't discussed yet, and perhaps something that is probably quite useful for us to think about in how we get that message across.
It's a really good point. And if you look, sorry, Alan, go on.
No, I was just about to say, Rachel, especially the GP appointments, absolutely, people still prefer to go in. I think the challenge is going to come is when there's not enough doctors, how do you service the population? I think that's when it's going to be more in need. Sorry, Rachel.
I actually, looking at the cost of outpatient appointments, some of the services I was looking at, it was £100 odd per outpatient appointment. And a lot of cost was in space, in rooms, in inefficient process. And actually, if you play that out for some people, we played some of those financials out, the building that we're putting in, we wouldn't need, and this, that, and next. And we play that out to patient groups. They are quite interested because it becomes real for them. And so we are operating ineffectively and inefficiently. And so, I think it's a big conversation we need to have around where the money in our care system, our health system from our charities go.
Because I think 30% of hospital space is waiting rooms.
It is indeed, yes, yeah. So. It's a lot to heat, light, service, water, everything.
I was talking to a GP in my area recently, and they came up with a new way of trying to treat pre-diabetics with using dietitians in the community. But the dietitians would send the patient to the hospital to get their bloods taken, the HbA1c test done. The patient would have to catch a bus to go to the hospital, which could be 10, 15 miles away, have their bloods done, then are sent home, then go back a week later to the dietitian to get the results. There's lots of needless travel, increase in their carbon footprint, et cetera, which could be removed, even if it's not technology going direct to the patient, but just maybe in a community centre where you can go and just connect with healthcare services. Doesn't need to be, and then you don't need to be particularly well versed in technology if somebody's there to help you.
That's a good point, Paul. The green agenda, again, there was a piece of work done, and I can't quite remember where, but a surprisingly high % of traffic on our roads is related to healthcare. And you know, that's another good reason why we should do this. So I think there's a lot of narrative around why we should do things differently. Now, people have got used to not getting a free plastic carrier bag or not using plastics or whatever else, and people are adopting that at every age band. But can we make that same sort of Greta Thunberg like you know, debate play out around healthcare, around sustainability, around greenness? I think there's a bigger agenda around health and care to play out.
Rachel, thank you. Yes, I completely agree that intersection needs to be played out. A really good point there. We are going to close questions in a minute. I just have one quick one for Simon. I don't want to finish on a too much of a negative note, but hopefully you can provide you know, an insight into some of the positive moves that have come out of this. But we do have a question that has come in about what scams you might have come across and how did you deal with them? We've only got a minute or so to do this, and then I'm going to have to wrap up, but I'm keen to get your thoughts on that.
So generally speaking, it's been the same sort of scams we'd see all along, just focusing on the crisis and playing on some of the current issues around isolation. So things around you know, doorstep scams, offering to pay for or get shopping in return for cash and payment, various text-based scams, pretending to be someone from the government, etc. So we've done quite a bit of work. We actually joined forces with some of the other older people's charities, some of the Alzheimer's charities as well, in looking at providing some guidance for this. The difficulty with all of this thing, as I think someone else pointed out, one of the questions is actually how you get this information out to people that aren't online. And again, very, very difficult, not one we've got the answer to right now, but again, using and working through some of these community groups, community organizations, we're starting to get some of this information out there to the people that really need it. But as I say, in terms of scams, there's always going to be people, unfortunately, take the opportunities. But I think what we have seen is a lot more positive initiatives started at a community level that we, I think as a charity sector, are trying to work really hard to build and support now as well.
Great, thank you, Simon. And thank you to all the panelists for answering those questions. Thank you to all the delegates who put all those questions forward. I'm sorry we couldn't get through all the questions. So thank you to Simon, Rachel, Alan, Paul and Kevin for all of your engagement and answers. Thanks for the contribution. That was a really great session. We found that food scarcity was taken granted before COVID-19 pandemic. We learned that isolated individuals can benefit from innovative solutions to get food and drugs to the door, but we also learned that digital isolation needs to be tackled to open up access. I think we heard that people are falling through the cracks before the pandemic are the same people that are falling through the cracks now, but at a faster rate, and they're being hit harder. But what we also learned, I think, is that through collaboration, through discussions like this, through forums like this, through ingenuity, business and charities working together, we can make a real difference. I'd quickly just like to say that we would love the opportunity to talk to any of you about our work from an organizational perspective, how we can connect your business to other businesses, to policymakers and relevant stakeholders, and brand exposure through our events and activities and collaborative work that we can engage with you on. So please do contact me on my email address if you want to have that discussion. I'll be really, really happy to talk to you. I'd also just like to make you aware of our next Future of Aging conference taking place on the 3rd of December this year at the Wellcome Collection, where we'll be looking at delivering a better society for all generations. Thank you again to all of our speakers. Thanks for everyone who joined, and a special thanks to EY for making this happen, and our members and the ILC Partners Programme for making everything possible. This has been our first webinar in a series that we have planned over the coming weeks and months. For news on all of our latest webinars, please stay up to date with all ILC news on our website, ilcuk.org.uk. Thank you.
Thank you.
Okay, I just clicked stop share.